without insulin, you die. And there's a reality that in Africa, about 1 in 2 people with type 1 diabetes is likely passing before they're even diagnosed or linked to care. I think what we're seeing from insulin manufacturers is that overall, there are opportunities to expand access. It's not really about the innovations at this point, but rather how do they support delivery and scale. 1 in 2 people with type 1 are missed before they're even linked to care. There's a huge swath of people with type 2 diabetes who also need access to these supplies and are not being linked and treated with care. But I think the reality is when you invest in equity, you're enabling innovation, you're creating new markets, and you're laying the groundwork for what's to come.
Welcome back to the Health Equity Podcast. I'm Iyer, CEO of the Access to Medicine Foundation. Today we'll be focusing on type 1 diabetes, a chronic disease that can be managed by access to life-saving insulin. In many low and middle income countries, the life expectancy of a person living with type 1 diabetes is 19 years of age, compared to a high-income country like the US or Europe, where people can live up to 75 years. To discuss this inequity and what we can do to solve this, today I have a guest with me, James Reid, who's a program officer of the Helmsley Charitable Trust Type 1 Diabetes Program. Welcome, James.
Hi, Jay. Thanks for having me. Happy to be here.
James, what first drew you into working on type 1 diabetes and what continues to motivate you in addressing this issue?
First, it's really what you just said. I think the fact that life expectancy in low and middle income countries is more than 50 years lagging behind high income countries is really a stark inequity. It's an injustice. I think in many ways, it's one of the most glaring health equity injustices of our time. Type 1 diabetes is a fully manageable condition with the right supplies and support, but we see that lagging incredibly far behind in low and middle income countries. At the same time, we know from other global health work that those type of inequities can be solved, they can be remedied. Before working in diabetes, I spent a lot of time in HIV. It's a really different situation with a lot more resources and momentum behind it. But what we saw after decades of work and collaborative effort, that those equities can be closed, but also that low and middle income countries can actually move faster and reach innovation quicker when partners work together. So what keeps me in this fight is really believing that we can do something and knowing it's possible with consistent effort.
And so tell me a bit about Helmsley Charitable Trust's work in sort of driving investments and sustainable solutions. What kind of partnerships do you invest in? And, what kind of work do you do in that?
Helmsley Charitable Trust, I lead our work in low and middle income countries within our type 1 diabetes program. We're the largest private philanthropy focused on type 1 diabetes, and we've invested over $1 billion in the cause, understanding the disease, changing the trajectory of the disease, and improving access in the US and abroad. Within our LMIC work, we really focus on the reality that we need to address those urgent needs. Without insulin, you die. And there's a reality that in Africa, about 1 in 2 people with type 1 diabetes is likely passing before they're even diagnosed or linked to care. So we spend time investing in programs that aim to reach those patients quickly. But the majority of our investments are actually focused more on making lasting systemic change, helping build commercially sustainable markets, and improving the underlying health systems that treat and support people with non-communicable diseases overall.
So in our work in Access to Medicine Foundation, we've been for several years evaluating how the pharmaceutical companies that produce insulin have been addressing access to care in low and middle income countries. And we had a recent pediatric care report that we published in 2025. And there we showed that type 1 diabetes outcomes remain unequal for children and young people. Less than 10% of an estimated 800,000 children and young people living with type 1 diabetes were reached by these access programs across 70 low and middle income countries in 2023. So, given your strong commitment and Helmsley's strong commitment in pediatric type 1 diabetes, which areas of the access ecosystem do you think we're already seeing progress in, and what's still left to be done in order to ensure that we're seeing that sustained bridging of equity gaps?
First, I think it's really important to recognize that the pharmaceutical companies are making really big commitments to this space. I think sometimes the insulin market is characterized in a way where the pharmaceutical companies are to blame. I think the Access to Medicines report really painted that it's a much more complex picture. These companies like Lilly, Novo Nordisk, Roche, are making donations. Sanofi is also advancing its own access initiatives. And those are really bold programs that the companies are taking on, really with the intent to save lives, addressing that same urgent need that Helmsley is doing. I think what we see is that, as you said, less than 10% of just young people is not nearly enough to reach everyone or reach scale. So the largest gap that we're seeing is really that each individual partner is ultimately working on important initiatives. Oftentimes, these are donation programs, working on training of healthcare workers, improving patient education materials. But the research sort of highlights that these are often fragmented, they're time-bound, and they're not necessarily aligned with what governments are planning for their larger health systems. So as a community, what Helmsley has been promoting is to think about two specific aspects. First, we need to engage governments early and often about how type 1 diabetes aligns with their type 2 diabetes program, their hypertension, their broader non-communicable disease, and frankly, the whole health system writ large. We don't really have the luxury of sort of addressing this problem in isolation. So how do we make sure it weaves into the other priorities that the government has? And I think second, we need to recognize that this is a holistic issue with many, many parts. How various elements of the ecosystem come together, become interconnected, and build off each other synergistically. We see this in HIV, but other areas like maternal health or vaccines. When partners are working together in tandem, you build much more healthy markets. So that means addressing things like the underlying healthcare worker force development, along with data systems, along with supply chain challenges, along with those service delivery models for type 1 diabetes. If you address those in isolation, then you ultimately are not sort of having a collaborative effect. And it makes sense that there are really significant market challenges because they're fragmented.
The diabetes market is concentrated on a few players that you've just mentioned, right? And currently, we're also seeing that there's a number of analog insulins that are now seen as standard of care and offer a lot of choices to people and practitioners so that they have options available to treat chronic diabetes. At the same time, I think there's a large inequality and lots of unaffordable access to some of the newer analog insulins that's actually there, despite being introduced into the World Health Organization's essential medicines list. What's really the problem in terms of access in these markets, and how do you think we can solve that?
Yeah, absolutely. I mean, to put it in plain language, analog insulins were introduced in high-income countries like the United States in 2000. That's over 26 years ago. That's a really, really glaring gap in the standard of care. There is a lot of evidence emerging, and WHO is currently reviewing how analog insulins fit into the overall recommendations globally. But what I think is unacceptable is that a child born in Europe or the United States is receiving a completely different standard of care. I wouldn't allow that for my child, so why do we allow that for children in Africa? So what it comes down to oftentimes is that there is not this sort of interlinking between players. The suppliers and the pharmaceutical organizations are really concerned that there's not clear data on the ground, which makes it difficult for them to introduce products at an affordable price or change their supply planning because there really isn't consistent demand. In countries, there remains to be challenges in terms of updating their clinical guidelines, training healthcare workers around a more complex, what's called a basal bolus regimen instead of 2 shots a day. There's a lot more decision making. There's less data systems to support that quantification and understanding of how to order. And there are financing challenges in country, but those sort of go hand in hand with those pricing challenges I just discussed. So there's a bit of a role for philanthropy to step in and make sure we're connecting and building bridges, designing and piloting models that will address some of those challenges, really so we can bring those supply and demand sides together and really come back to the current standard of care we're seeing in high-income countries.
What should we expect the pharmaceutical industry to do? Invest more in all these different areas, partner up, make sure that the availability of insulin and the way to deliver insulin is actually available in these markets while waiting for all these systems to be invested in? And
Yeah, no, it's a really great question. And I think you hit the nail on the head there. You said partnerships, right? I think in the current era of global health, especially all the changes we saw in 2025, there's a reality that no single partner can do everything. Gone are the days where we can sort of think about a singular bilateral or multilateral player that will choose a disease and build up all those health systems from the bottom up while providing supplies. So what Helmsley has done is sort of think about new mechanisms and models to help build that out. Recently, in the fall of 2025, we came together with Breakthrough Type 1 Diabetes, a public philanthropy here in the States, and formed a new coalition called the Align T1D Alliance. And really the idea is to do what I just said. So think alongside governments about what their major priorities are, and then think about the whole ecosystem. Look at what everybody's funding and try to identify gaps that we can fill rather than sort of piecemeal activities that address individual challenges. And I think what that does is allow partners to really specialize where they can play to their strengths. There's a reality that many pharmaceutical companies can make really valuable investments, especially in health system strengthening initiatives. Those data systems are something that could really benefit everybody and really have sort of long-term gains for companies over the long term. And philanthropies like Helmsley can focus more on things that might induce conflicts of interest. So how do we support organizations like WHO to develop their clinical guidelines, help adapt those at countries, improve how countries are forecasting and quantifying their demand? And that's exactly what Helmsley's doing. So really with Align T1D, we're asking folks to come along with us and help fill those other parts of the pie while we focus on elements that pharmaceutical companies can't.
So which areas have you seen tangible progress and a lot of strong momentum in terms of making the change that we need to see to address some of these gaps in access?
Yeah, it's a great question. And I'll admit, I think there are questions about how a complex disease like type 1 diabetes can be addressed in low resource settings. Helmsley sought out to answer that question, and fortunately, we've landed in a good place. Integrated service delivery of type 1 diabetes is probably the place where we've made the most progress. So Helmsley invested in understanding of how do we move type 1 diabetes out of siloed specialist clinics and make sure that it's part of the overall healthcare delivery system. So that model has evolved into something called PEN+. It's been endorsed by the World Health Organization in the Africa region, and it's been a real rallying point to think about how chronic severe NCDs overall can be treated and layered onto the existing NCD health system. So diseases like type 1 diabetes, sickle cell, rheumatic, and other childhood heart conditions are paired together at first level referral hospitals. And that really sort of helps improve how rural communities are accessing care. It expands the coverage of care and helps make sure that there's an ongoing training and mentorship program that helps empower nurses at lower levels to take on those conditions in a sustainable way. And what we're seeing is really impressive. We're seeing huge gains in the number of patients across those diseases being covered. We're seeing improvements in outcomes for patients, improvements in healthcare worker knowledge and understanding of what to do. And I think most importantly, and this is a big question that comes up from philanthropy and the private sector, we're seeing real buy-in from country governments to take that on and scale it in a real way. Just a couple weeks ago, Ethiopia launched its own national operational plan for PEN+. They're one of several countries that have come online in doing so in the Africa region, and they made some really bold commitments there. It's one of the largest countries in Africa, and over the next 6 years, they're planning to scale PEN+ nationally. They estimate about 70% of that plan will be covered with domestic resources, and about 30% of that will be supported by partners and other donors. So it will require some additional rallying, but at the same time, that 70% is quite a shift from what we see in the overall macro level data on NCD financing, where just about 1% of overall financing is going to NCDs. So what we've learned is really when we develop models, work with the government to create a shared plan around how to adapt that to the national strategy, governments are bought in and willing to pay their part. And there's a matter of other partners coming along to complement that and help scale it. And we've seen that really happen already in countries like Rwanda and Malawi that are a bit farther along in that national operational planning. Rwanda, for example, is almost fully domestically funded and nationally scaled in how they're covering Pen Plus. And that's a real bright light for how we think about the future of type 1 diabetes care.
So you expect that more philanthropic organizations can really start investing and getting on board on not only addressing type 1 diabetes outcomes, but also across many components of pediatric and adolescent care.
Absolutely. I think these national operational plans are quite a rallying point. What they really do is articulate what the government's vision is and where there are gaps. So some of that comes down to service delivery. Some of that comes to those health system building blocks that I mentioned earlier that are sort of holding back the overall progress. So we're seeing countries, Malawi's another great example of where a lot of partners have come together. UNICEF, along with Lilly funding, World Diabetes Foundation, Helmsley, the Scottish government are all rallying together around that plan. Malawi is one of the lowest resource countries in Africa, and yet we're seeing real gains in how they're covering and supporting people with severe chronic conditions. And overall, that's having a benefit to the government as a whole. They're spending less time on complications from these severe conditions and expanding their overall coverage, which allows them to take more on at the primary healthcare level.
How does access-oriented philanthropy look like in the coming years? I mean, what should philanthropists really be looking for and looking to invest in, and how can they do that?
Yeah, it's a good question. And I think over the last year, I think this has really changed the global health landscape overall. The reality is that the tools and approaches that really move the needle for diseases like HIV or TB or malaria are not going to work for the new future of global health. Again, we can't really rely on singular players to completely move the needle. In those diseases, there's been large procurement efforts and market-shaping organizations step in and address through large volume guarantees and that sort of thing. I think the reality is that in the new future of global health, we're going to be needing to think much more collaboratively. We're going to have to spend real time and energy on setting up systems and mechanisms where we can share jointly, develop shared strategies, spending more time engaging governments as a collective to reduce the burden on governments so that we're introducing and responding to what they need rather than what I'm thinking about in my office as a good idea or what may work on paper, but rather spending a bit more time. I think that shifts the narrative a little bit from making taking credit for everything by ourselves or sort of sharing its own story by ourselves. It puts a little bit more pressure to make sure that we're making long-term lasting commitments. It puts some onus on us to invest in having those conversations, having resources and teams consult with partners in country. Those things take time and maybe will move a little bit more slowly than what we've seen in other areas. But I think that's how we build really lasting change. I think mechanisms like Align that address the full overall ecosystem set up a real tangible entry point for private sector to join philanthropy. And for elements of that strategy, again, like the integrated service delivery, there's already shovel-ready opportunities like Pen Plus to join a coalition of partners. And so I think access looks like scaling together rather than scaling alone.
So for a person living with type 1 diabetes, they not only need access to insulin and the newer standard of care that's available, they also need access to glucose monitoring strips, continuous glucose monitoring devices, and a number of different innovative products itself. What do you see as the biggest barrier to getting access to this, and how do you think we can address that?
Yeah, I think it's a really interesting point. First, I think insulin does get a lot of attention, but in order to really manage type 1 diabetes, it really starts with empowering patients to take care of themselves. This is not a disease that requires a pill a day and sort of one healthcare worker sharing a simple solution. It is a complicated disease that takes a lot of decision-making throughout the day. I think the biggest barrier that we're seeing is that ultimately sometimes there is not a culture of empowering patients to take on that role. And when we think about children, there's an added element of making sure that parents and other caregivers are educated and understand how to take on those responsibilities. But we're seeing real progress in that. We know that when Patients are upgraded to more complicated regimens like basal bolus and analog regimens. Over time, we see really massive gains in outcomes. A study from Mali came out from that just last year from a group called Santé Diabète. That sort of regimen is also empowered and coupled with ongoing glucose monitoring. It takes some time and some training to work with patients and families to understand what that work has done, but I think we've made really good strides in that space. To give you a specific example, Find and Life for a Child worked together to advocate and made some real successes in terms of including blood glucose monitoring, self-blood glucose monitoring, not just at a facility, in the essential diagnostic list with the World Health Organization. And the next challenge is to sort of make sure that those are adapted and incorporated into national standards of care. We know that it's feasible, and a lot of countries are taking this on, including within that Pen Plus model. So I think it's a matter of sort of committing and understanding and also reorienting away from maybe simpler healthcare delivery models and thinking more about self-care and the patient's role in taking on their outcomes. I think in doing so, that's a bit of a leap, but at the same time, again, is a little bit of a benefit to the government and the health system where they partner with patients to take on some of that burden rather than trying to spread themselves thin and take over every single blood glucose monitoring on an irregular basis. Doesn't work out for anybody.
And what's the message then for companies that actually produce some of these particular products? I mean, at the foundation, we've actually brought a lot of players together, and you've been part of some of those discussions. Players that produce insulin, players that produce glucose monitoring devices and strips, and communities on the ground who really are responsible for that health system strengthening and educating and empowering people to understand the needs and understand how to manage the conditions on their own. What's the message that you can bring to some of the companies that are developing this, and how can we as a foundation also support that level of partnerships?
Yeah, I think that the questions are a little bit different between insulin and device manufacturers. I think what we're seeing from insulin manufacturers is that overall there are opportunities to expand access. It's not really about the innovations at this point, but rather how do they support delivery and scale. I think those investments will also yield longer term returns for the company. They'll attract investors and also lay the groundwork for other products that are in the pipeline. For insulin manufacturers. For device manufacturers, I think there's a real question. In many countries, there's a real fragmentation of what blood glucose monitoring is available or what continuous glucose monitors are available. And for patients, what we see is real concerns with the quality and the consistency of these devices. So I think there's a matter of working with regulators and making sure that there's a clear understanding of quality to make the case. Some of that burden is on countries, of course. But there's also sort of an onus on companies to make sure they're earnestly making commitments to quality and consistency. How can they align and improve access in a consistent way? Sometimes what we see from the device manufacturers is that devices are donated alongside purchases of strips, and then years later, those devices change, the strips change, and then there's sort of a complaint from the companies that there's not consistent demand, so they can't plan. But the reality is, if there's changes without being needed changes to patient outcomes, it doesn't work well for the countries or patients, and it doesn't work well for the companies. So how can you sort of think with that demand-oriented design planning to make sure your products can reach people over a long period of time?
And developing sort of ensuring that there's enough sufficient demand is something that many players in the industry sort of wait for, right?
Yeah.
While donating their products into quite effective programs at the end of it. How can we actually solve that demand generation, demand planning ecosystem so that it's a bit more stabilized in countries, and we can have sustained levels of supply of many of these products?
Yeah, I think it's a really interesting question. I think there's sort of a perception that there is low demand, and the reality is that we're really not capturing the people at all. Like I said, 1 in 2 people with type 1 are missed before they're even linked to care. There's a huge swath of people with type 2 diabetes who also need access to these supplies and are not being linked and treated with care. Some of the strategies that Helmsley has been supporting is really to improve and simplify and decentralize care. So an example of this comes from Ethiopia, where we supported the Clinton Health Access Initiative to pilot care models at more of a primary healthcare level, but also to invest in some of the really foundational elements that we see in the infectious disease space. So that's what really simple, kind of classic global health initiatives. How do we work with the government to set up a regular technical working group and make sure partners are coordinating on an ongoing basis? How do we adapt clinical guidelines? How do we set up shared training modules? How do we simplify the training for healthcare workers so that they can regularly follow simplified modules to help identify and link patients to products? And what we saw at pilot sites in Ethiopia is a threefold increase in procurement in just a couple months, while we saw massive gains in outcomes for both type 1 and type 2 patients. So it's feasible. I think the reality, it just takes a little bit more commitment and focus. There is maybe a perception, and maybe what we've learned from other healthcare areas is that this will happen, other players will step in. But again, there is not that one singular player. And so we need to be thinking about how we partner with governments to set up those foundations and build from there. And I think we're seeing real progress in the countries where we've made those investments.
I mean, the concept of there's not enough demand has actually gone pretty far in the insulin space, right? So much so that several companies, these are large pharmaceutical companies, are more focused on the weight loss market than than the insulin market itself. Are you concerned about this? And what should we as a society be doing to make sure that our search for weight loss treatments doesn't take away access for a child living with diabetes?
Yeah, I mean, I think it's a really interesting concern and something we should keep an eye on. The data is really telling a bit of a different story than what we're seeing in headlines or sort of projections. There is, of course, a very healthy, high-income market, commercial opportunity for companies to be pursuing with things like GLP-1 antagonists. But what the data is showing is that there's still a massive growing demand for insulin and other related products. For type 1 and type 2, both are growing in incidence overall. And we expect over the next 10 years, based on, a Clinton Health Access Initiative market report, that those markets will continue to grow. Globally, especially in low-income countries, we anticipate that there's still a lot of room to capture markets for type 1, type 2 insulin, blood glucose monitoring supplies, even as there's sort of a rise of GLP-1s in high-income markets. Right now, those markets are quite bifurcated, and as we discussed, there's a real difference in the standard of care. And I think if companies are not thinking ahead about investing in, again, those delivery systems, the underlying health system building blocks for insulin, then they're never going to make it for GLP-1. So I think it's reorienting around, from a commercial lens, I would be thinking, how do I invest in my future markets? I think there's maybe a falsehood that investing in equity takes away from innovation. But I think the reality is when you invest in equity, you're enabling innovation. You're creating new markets and you're laying the groundwork for what's to come.
Including future innovations in other non-communicable disease areas.
Absolutely agree.
You've also been part of some of our convenings where we've brought together a range of different partners to unpack what strong collaboration can look like. Partners who've really worked on the ground activities, really have convinced people within their companies to invest more. From your perspective, is the real gap that we need more partnerships, or what we have can be scaled up to be more effective and more sustainable?
I think first, starting with the convening point, I think Helmsley has been really intentional about our partnership with the Access to Medicines Foundation. There's a reality that the discourse on insulin, I think, has not been very constructive historically. There's been a culture of sort of saying this is a very high-priced drug, it's a life-saving drug, and therefore companies are not doing enough. This culture of sort of naming and shaming, which I think comes from a place of advocacy and real concern for patients, which I can certainly understand. I think where the Access to Medicines Foundation has kind of changed that narrative is really approaching those conversations with more of a database lens, looking at evidence about what companies are doing well and where they can improve. And the reality is it's a little bit of a mixed bag. It's not quite a black and white story. Companies are, of course, a part of the solution, but they're not the whole solution. Like I said, no partner really is. So I think when we first started going to Access to Medicine Foundation convenings, I will say there was a bit of hesitancy from the companies in the room. I think they were a little worried that they were going to get a gotcha moment, that they were going to be sort of in trouble in a room full of angry advocates. But I think addressing that conversation in a really constructive, problem-solving oriented way really helped build some bridges and understand some shared understanding. I think companies were opening about their challenges and where they had struggles in expanding their access initiatives. And similarly, NGOs, governments, advocacy organizations at those meetings shared some of their in-country struggles as well. And I think we really saw kind of a culmination of this last May in 2025. Helmsley and ATMF had a public forum which featured all of the major insulin manufacturers, which includes Sanofi, Novo Nordisk, Lilly, and a biosimilar company called Biocon. And we also brought together the World Health Organization, country representative advocates to have that conversation in a really public way. And I think we reached a really interesting turning point. I think that report was a bit of a wake-up call that these organizations, to your point, need to be thinking more about partnerships, and they can't be acting alone. And what I heard in that conversation was a real willingness to think about how do we combine and work towards our strengths? How do we build on the World Health Organization global diabetes targets to inform what we're prioritizing in country? And I think one thing that kind of stood out for me, John Ferris, the head of the Global Health Unit at Sanofi, made a point that really stuck with me. We need to move away from these forums where we're talking and move into actual practical action. And I think what we've seen is that Sanofi has making strides, including with some of the recommendations from the Access to Medicines Index, to think about how they can create a secondary brand, think about that as a way to establish a commercially sustainable, lower cost insulin product line, but also other products under their impact brand. So I think moving those conversations and data into action are really important, and that helps with scale. I think there are, again, some initiatives that will need more partnerships for those to work. And again, that goes back to some of the initiatives that we talked about to make sure that analog insulins can be introduced, that we have a better understanding of demand. And some of those things realistically step outside of what industry can do alone. So how do we tie some of those, the willingness to engage on price in a secondary brand with some of the progress that we're making in improving delivery and health system building blocks? So I think to answer your question, partnerships or scale, it's probably a little bit of both, and they do go hand in hand.
I mean, what was really quite remarkable is some of the companies actually made sure, in order to come to the convenings, to sort of unpack problems and sort of offer different types of solutions. They made sure that internally they would get much more buy-in, and also brought to the meetings extra commitments, extended commitments into their work itself. And what was interesting is when you have multiple companies in the room, including companies that are waiting for the market to solve itself, they sort of empower each other to sort of say, okay, this is the way we have to sort of move together in solving these problems. And I think consistently reporting on the progress that is then achieved over time is a model to show that, there is a level of accountability. So we don't only talk, we also end up in a system where performance is measured and done in that sense. Yeah,
I completely agree. And I think that culture of accountability really needs to extend across all partners. I think if we're thinking about a reality in which every partner has a hand in the solution, we all need to be sort of transparent about what we're doing and how things are going. And that includes philanthropies like Helmsley. I think another good example of that sort of open monitoring, reporting, and accountability, we saw a really interesting exchange from Eli Lilly and from Novo talking about how some of their licensing partnerships were proceeding. And I think Novo was sort of transparent in the fact that they have some room to grow to expand those, while Lilly was making some progress. Other partners like Biocon were talking a little bit about their supply challenges and how they're trying to expand their line so that they can reach more people. I think being open in that way also sort of gives partners some understanding that these companies are working in the right direction. There's really an intent and an understanding that there's both an access and a commercial opportunity that they're pursuing, but it requires a bit of shared investment and understanding from other partners. Lower cost licensed product from other partners, again, are not really going to be taken up sustainably if there's not sort of a system to catch them on the other side or to demand those products. So how do we meet partners halfway in what they're pursuing so we can build that healthy market?
James, you spent time in Sub-Saharan Africa. You've seen what works and what doesn't. You've also spent a number of years working on type 1 diabetes. What are your hopes for the future for people living with type 1 diabetes? And what's your main message for the pharmaceutical industry, for people, whether they're from institutional investors or from philanthropies or as individuals looking to invest and collaborate on bridging some of these health equity gaps?
First, I would say closing the type 1 diabetes gap is achievable. What really matters is how we align our resources, our will, and our efforts to make sure that we're complementing what governments and people living with type 1 diabetes want and need. I think traveling to various countries to visit some of our projects and seeing where we've invested, I think the reality is that this is a long game. This takes some time. Philanthropy plays a really important role in designing and testing models that can scale. But when we stick through those efforts and bring other people along, we see real progress. I think a real highlight for me was just this last year in February around the NCD Alliance Forum in Rwanda. We were able to visit one of the first sites that Helmsley invested in with Partners in Health. What we saw there was frankly incredible. Partners in Health is a really well-run, well-known partner that has been doing a lot of challenging work for a long time. They helped develop and establish what is this Pen Plus model. But what we saw there was when we were joined with government partners, visiting clinics that were outside of sort of the overall purview of Partners in Health, that there had been real government progress and ownership of that type 1 diabetes care in an integrated way, reaching really rural communities that otherwise would have to travel hundreds of miles to get care. And we saw empowered patients understanding their ability to take care of themselves, how to safely receive their insulin, how to monitor their blood glucose. We saw engaged providers who understood sort of the latest ways to treat and educate their patients. And I think most inspiringly, we met a young man who colleagues at the Helmsley Trust had met a long time ago, probably about 10 years ago. At the time when we were just starting, he was frankly struggling. I think the reality is that sometimes we go to these countries and wonder, is there going to be care for them in the future? Are they going to be able to make it with this disease? And this young man, I think, was not only living, but thriving in a very real way. He had a family. He was now married. He had a child. He was an English teacher and pursuing higher level of education to work into a higher level of care. So this, at the end of the day, wasn't really about type 1. It was about how he became a member of society. He's advancing his community and his own family. And that's thanks to the fact that the government really had invested and partnered with our initiative and built alongside others to scale that. So in many ways, Rwanda is ahead in some of this, but I see this future for many, many other countries. As partnerships come together and align their efforts in a similar direction, we can make real tangible change. And that has real personal impacts for people.
Thanks, James, for sharing your thoughts and inspiring us with the fact that progress can be made, has been made, and needs more attention.
Thanks for having me.
In today's episode, you've learned a bit more about type 1 diabetes, a chronic disease that can be managed with access to life-saving products. A lot of significant progress has been made in countries, also with the help of investments by the Helmsley Charitable Trust and its partners. And we've showcased the different levels of progress and the gaps and opportunities for how you can take actions on addressing this unacceptable gap. Thank you for watching the Health Equity Podcast.